echo just now, you can appreciate the level.
Thanks, Sheikh. So I will, first of all, like to thank you and host and the rest for having us as part of the program for this year's CSI. And I will start with a talk on the IBS iron stent. Shall I start with a talk on the stent first? Can you put the slides on?
Yeah, I assumed IBS was irritable bowel syndrome, which is what I've got. But
all right. Okay.
Go ahead with the stent.
Right. Okay. So this is my disclosure slide. Right, I think we all realize that the literature on this bioresorbable stent in children and infants is very limited, partly because the developments of this has really been mainly in the coronary artery arena. And we know that this is an area which is very much unmet in terms of needs, especially when you look at these pictures here, an infant with severe RPS stenosis, and here another one with very small closing PDA supplying to a left primary artery in the station of a tough absent primary valve. And we know that this kind of patients will require complex operations, and therefore it does make sense if a stent can be placed which dissolves, and then later we can allow more stenting and also probably a better surgical reconstruction. At the moment, what we have is the McMurray stent because the absorb from Abbott has been withdrawn. So what we have been using recently is a small study, pilot study on the iron resorbable stent or RBS from Shenzhen LifeTech Corporation. So as we know that in PDA, most of them are complex, and many of these patients in whom we stented the PDA is just a temporary measure whereby we will need to subject these patients for complex reconstruction surgery. And probably it does make sense that something that is resorbable is going to be beneficial because a BMS stent, which doesn't dissolve, has an impact on surgical repair, especially when we perform the surgery late more than a year or so. And this is a small series of surgical outcome in patients from Italy, whereby, although a small number, but 3 out of the 13 patients, they could not really remove the stent entirely. And this is shown also in our patient here as an example, whereby after stent about a year, we did the repair, and you can see that it's not really possible to remove all the metallic parts of it out of these patients. Nevertheless, the patient had a good surgical outcome. So what we have embarked on is to look at the clinical safety and efficacy for PDA stenting, although this is really a stent which is developed by LifeTech in Shenzhen for coronary arteries, which is coated with sirolimus. But we have requested that we want to look at this in neonates for PDA stenting. And basically, this has been many years in development, and what they have come out after many animals testing, that this stent is iron-based. They have managed to bring down the struts really thin, to 70 actually. But the stent, instead of just iron and PLLA with sirolimus for the vehicle for sirolimus, they have put a zinc layer on top of the iron so that it degrades only after 3 months when the zinc dissolves. So there had been a study which was just recently terminated in which centers in China and one in Malaysia took part in that. So I will go quickly to this. So just to compare the bench testing of the IBS stent as compared to science from Abbott. The strut is a lot thicker, I say significantly thinner than the science stent and most other cobalt chromium stents. In terms of radial strength, it seemed it was comparable from the bench testing, and also in terms of crossing profile, which means that we can use a 4 French sheath as compared to the other bioresorbable stent, which required a 5 French sheath. Right, and also I think in terms of what has been known from the animal studies is that we should see the iron dissolving after 12 months or up to 24 months. So with that, and also just briefly, what has been monitored from the animal studies is by using micro-CT, MRI, as well as OCT to see that at what stage that the iron starts to disintegrate or gets corroded. And this is what they have seen in animal studies, whereby by 13 months we should see some disintegration significantly of this iron stent. But what we have done is that from September, we started to recruit. The aim is to have 10 patients over a year. And what we are doing is basically to limit first as a pilot study to simple PDA morphology, which means that this kind of ductus, which is fairly straight, that comes off from the descending aorta, in which case quite often that the stenting procedure itself is fairly straightforward, but bear in mind that these are very sick infants, usually with PIVS or critical PIS, which need balloon dilatation and thereby makes them quite sick. Therefore, we might say that it is a simple morphology, but the patients are not that simple in terms of hemodynamics and clinical condition. So what we were looking at is how they handle the visibility on X-rays, the acute results in the cath lab, as well as the post-procedure ICU results, as well as how does the stent performs after discharge from the hospital. And the exclusion is patients who weigh less than 2.5 kilograms and age more than 3 months. I will not go through this. So these are examples of a simple-looking PDA which has been stented. Right, so comparing a coronary as well to a PDA stent, what we are worried about is that when it comes to something which is going to be corrodable, biocorrodable over time, you don't have this kind of overhang in the coronary arteries, but when you do that in a PDA, there is bound to be some overhang on the MPA in the pulmonary arteries, maybe in the aorta. So because the concern here is that as the stent gets absorbed, parts of the stent might become lost in terms of integrity. It moves with the pulsations and parts of it might break off and migrate somewhere. Therefore, our aim is really not to have any overhang or very minimal overhang on the aortic end from the very start. So I'll just like to show our very first patient that we recruited about in September last year, and this is a patient with PIVS, very high RV pressure, mild tricuspid regurg, but very high, very severe pulmonary RV hypertension. That is the small right ventricle after balloon dilation. And this is looking at the PDA itself. Yes, this is a nice PDA to stent, to implant a stent, fairly straight looking, with a fat belly, and no branch PA stenosis. This is crossing with the wire. Sorry. All right, and this is the angiogram once the wire has crossed the ductus into the main pulmonary artery. See that nicely, yeah? And this is then we make sure we try to make sure that the stent will not really jut out into the aorta too much, which means no overhang in the aorta as much as possible. And this is post-inflation. You can see that the markers are here, right at the end of the ductus on the aortic end, maybe a bit more on the pulmonary artery end. And this slide is showing the final results. This is showing the nice branch pulmonary arteries, unobstructed. The PDA stent just enough into the aorta, and this is the immediate post-angiogram. And if you look at this, you can see that the visibility is not as good, maybe 50% of what you normally see in normal BMS, but enough for us to have a successful implantation without much problem. And this is at 3 months, reasonable shunt, but at 6 months there is barely any flow across, but by this time the patient is well grown and she needed surgery for RVOT reconstruction, and therefore the stent was removed, and this was subjected to histopath as well as, sorry, we missed that. Subjected to pathology studies and all, but this was clamped by legal clips at the time of surgery, and therefore you can see a lot of fractures. But what we notice is that at 6 months that the absorption was still below 10%. Right, this is just to show that in some patients with very long ductus, the stent might want to jut out a bit. Therefore, we try to make it really fitting into the aortic end of the ductus, and we missed by a few millimeters. So we top it up with the cobalt chromium stent so that it doesn't jut out with the absorbable part. And therefore, you can see that in terms of visibility, it is not as good as the cobalt chromium, but enough. And that part is where the overlap of 4 millimeters between the cobalt chromium and the IBS stent. This is another example, the third patient that we did. This is the echo at the time of presentation, and this is 6 months after. The patient is now very well. There's no more tricuspid regurgitation. Nice RV, patient is pink, and therefore there's really no need for the stent to be patent anymore. So, but at clinic, we brought him to the cath lab for fluoroscopy, and we can see that if you notice here the arrows showing the dots, the markers at either end, this is the aortic end, but you can see the pulmonary artery end is now a small piece has migrated to the right pulmonary artery lower branch. But the patient is nevertheless well, and therefore this really brought again our concern that if we have the stent too much in the aorta, if this breaks off, it can cause some major problems. But if it is in the pulmonary artery, as in this case, we did in a way anticipate this, but this had no consequence, but probably we need to confirm that later with an angiogram. Right, so this is briefly our results for 9 patients up to July from September, and all of them except one case is really a case of cases of either pulmonary arterial intact septum or critical pulmonary stenosis, and 4 has reached about 6 months follow-up with one patient who who died after being well for 1 month at home, but presented with quite very symptoms which might suggest an infection followed, culminated with probably thrombosis. So that is really something which we felt very, very bad about. One of the complications, all the procedures were successful, there was no major complications, but one in the ICU had prolonged overcirculation, and this might have caused the NEC, and this patient had surgery but did very well at the end of it, and now is currently almost close to 6 months follow-up. So all were discharged well, but there was one mortality, as we alluded to earlier. So 3 patients, more than 6 months follow-up. But what we noted is that all 3 had a good outcome. But in terms of PDA patency, I think by this time, these 3 patients all had very, very little flow through the shunt, through the PDA stent. But by this time, the stent patency was not really crucial to the patient's outcome. So in conclusion, this is just very early results, but what we have found out is that the acute and early post-procedure results in the ICU, in-hospital results are good. We had no major problems, although the patients were very sick. And in terms of how easy it is to implant, it is very similar to BMS stent. But in terms of X-ray visibility, it is about 50% of what we find in cobalt chromium stents, but enough to have a successful implantation. But however, these are patients with very simple morphology. 6 months is the time when we need to start worrying, because this is when the flow starts to become reduced, and therefore, but this is also the time when the patients either no longer needs them to be patent, or the patients will need to be subjected to another form of operation, either Glenn shunt or reconstruction of the after track. So I suppose a large multi-center study is desirable, but I think in the longer term, what is important is that perhaps the major application of such stents, not just the IBS, but any other bioabsorbable stent in the PDA, is that most of the PDAs that we deal with are complex, and therefore we will need to test to see whether this stent is also applicable in such clinical situations. So with that, I would like to thank you for this talk.
Anthony, thank you very much for that very informative talk. Now,